Okay, I think that we'll get started now. Thank you so much for joining us here at the Center for Global Development for a very interesting panel today. Either our topic is passionately interesting, health system strengthening and metrics to measure health system strengthening, or our panel of speakers is so illustrious that it's really attracted such a large audience. I think it has to do probably with both. And I thank you very much for coming to CGD to talk about these issues. The motivation for this panel is, that health system strengthening is sort of a famously fuzzy, a vague concept. And we've all been struggling to define what exactly it means and why it's important to health outcomes. And so the discussion on metrics helps with trying to make the concept of health system strengthening more concrete. And that's what we'll talk about today. But there have been multiple efforts to measure health system strengthening and multiple frameworks in place. So that's something else I've asked our panelists today to address in more detail. We'll start with a keynote from Ariel Pablos Mendez, who's the Assistant Administrator for Global Health at the U.S. Agency for International Development. And we'll follow with a panel of Peter Berman from the Harvard School of Public Health, Karen Kavanaugh, who's heading up health system strengthening work at USAID, and Sally Stansfield, who's the former executive director of the Health Metrics Network. I don't think we could actually have a group of people who are more knowledgeable about this topic. I would also say that we're competing with a CGD-sponsored event with the candidates to the World Bank presidency. So this is another testament of the importance of this topic and the stature of the speakers. Okay, so with that, I will turn it over to Ariel for his comments, and then we'll all come up for the panel section. Thank you.
Thank you very much, and thanks for the opportunity to be here, and it's indeed great to have so many of you together. Many of you have heard me recently. I joined USAID only 8 months ago, and I've been really declaring my personal interest in the importance of health systems, but also a recognition of the trajectory of work in health systems that USAID has had over the last 20 years and beyond. I like to think in this bigger picture of what our field of global health has been and is becoming. We used to be tropical medicine, and with the end of European colonialism, we got rebaptized as international health during the Cold War. And with the end of the Soviet Union, we became global health. And the names pretty much demarcated these changes in the political economy. I believe we are in the midst of another such shift. Whether we're going to rebaptize global health or not, maybe there's going to be a blog about it one day, everything is changing compared to where we were last decade. And many of us have been living through that space and so can feel it. And in a way, part of the reason of this change is not so much politics, but in this case, it's about money. And so following the money in terms of measurement, that's not a bad thing, although health system is more than money. But we have been, I think, paying attention to the Grand Recession in the last 5 years as a possible trigger for some of the change, and it has indeed shaken some of the global enterprises and networks and organizations. But actually, I believe the opposite has been happening. That is, economics have been growing positive around the world in many of the developing countries in which we have worked. And we see indeed an unprecedented growth in median per capita income happening pretty much everywhere that USAID has been quite engaged working. At the end of this spectrum, of course, the BRICS countries and so on. But that this growth is bringing new challenges, but also great opportunities. The health expenditure in such setting follows the GDP and follows it rather closely in a way that is almost amazing, that you get R squares above 90% between GDP and total health expenditure. So health expenditure is growing with that growth in GDP around the world. And again, this brings new challenges and opportunities, implications for us, and Karen has been working with the team on a paper on the implications of this economic transition of health in the developing world for our work in USAID. There are many. First, we need to celebrate success, because development has been working around the world in the last 50 years for so many countries. And this also invites some bold thinking as to where we can go from here, where we were 20 years ago, where we are now, where we can go. And second, it also calls for engaging low and middle income countries in a different way than we did before. And that's already taking place as we speak, from BRICS countries partnering in development to many of those countries beginning to be crowded back in to take responsibility for investment in HIV, malaria, immunizations, and so on. And third, we need to change the way we work in USAID, in the global health enterprise. And some of this has already been opened up with the Global Health Initiative vision and principles. But in the end, it's going to be about working differently with the countries themselves. Among those big, bold goals that we can now begin to imagine as possible, just last year, President Obama announced the beginning of the end of AIDS, a vision for an AIDS-free generation, where HIV incidence that has been declining since 1997 and continues to decline eventually crosses the line of HIV mortality, and you begin to see a shrinkage of the epidemic. And this is already happening in several countries, and we expect the next decade to see more of that. And this is fantastic. But the second one that USAID is very much involved this year is envisioning the end of preventable child death in a generation. Under 5 mortality has declined by more than 70% in the 50 years of USAID's existence. In the last 20 years alone, more than 50 million children's lives have been saved. Again, occasion for celebration of success. But we used to have 13, 14 million kids dying. We now have about 7 today, about 7. If the world was to have the same child mortality rates that OECD countries enjoy, which on average is around 6, 7, but ranges all the way to 18 or so, if we could bring the world's rate of under 5 mortality to 15 per 1,000 births, that would be a tremendous accomplishment for civilization, and indeed we are on our way. And all of the modeling and all of the efforts that are now aligning around this idea suggests that we might do so by 2035. And now sounds like a long time, but actually in a post-MDG re-envisioning of goals, ending preventable child death in a generation should be one that I think the world will rally behind. So that's so because we can measure things, and we can begin to model things, and we can present this to the American people and other partners and policymakers that can do it. So measurement is paramount, and indeed I heard that health systems have been fuzzy, and I am a physician epidemiologist, not a policy economist person, but nonetheless I've been learning in the last 7 years or so about the importance of health systems for everything we do, and how to present this. And I was in WHO in the health systems cluster when the building blocks idea was put forward to try to bring it more tractable for lay people. There's people in Harvard with the control knobs, which I like very much, but we are sticking to some simplicity to communicate. We have also emphasized in the work at USAID, which is now moving to establish a dedicated office for health system strengthening. The measurement and evidence is going to be paramount, going in to make the case, to understand the situation, and that's something that USAID in particular has been a leader with the World Bank, WHO, and many others, OECD, when it comes to national health accounts around the world. And the numbers that I played before, and actually that we have plenty more, are only possible because we have national health accounts, which are imperfect sausage-making machineries, but nonetheless give us the best that before we couldn't even tell in developing countries. But also it's really important to have the evidence going out of the health systems. That is, how health systems impact society. And in particular, given where we are and the way advocacy is organized in America and on the Hill, how health system strengthening then leads to decreasing child mortality or maternal mortality. And I think that we have not done enough of a good job in that chapter. But whatever we do, we need to be able to have some measures, to have some consensus. And we were with Peter discussing the measurement of health systems universal coverage, and just measuring coverage. And we need to make sure WHO, the bank, USAID, OECD, all the big players agree on that so that we can begin to measure. Because I happen to believe that universal health coverage, which is defined as access for all to appropriate health services at an affordable cost, is the true north for health systems. And while people may find fuzzy to talk about health systems, they do not find it fuzzy when they talk about universal health coverage. That's too real. Is it possible in Africa? And of course it is, and it is happening now in much of the world, just as we've been having a big conversation domestically. So there will be many angles as to what is relevant measures, hopefully some synthetic measures as well, and finally a way to link that evidence, that measurement, to the outcomes that those who give us the resources to support this work care about. So I'm very much personally interested in the discussion here, so I will be very happy to join you in the panel, in the audience. Thank you very much.
Okay. Thank you very much, Ariel. I think that was an excellent introduction. He already answered one of my main questions, and that is, why is it necessary to connect health system strengthening metrics to health outcomes? And I think he's talked about getting those who provide funding for this effort to understand that connection. I think that's a very important rationale. But he's also posited a very large challenge, which is to get the many international organizations that work in this space together around a set of measures. So I'll invite my panelists to come up. I've asked them to answer, if possible, a couple questions. One is, why have previous efforts to establish global health systems strengthening metrics succeeded or failed, or have succeeded and failed in what aspects? How does the current work that your agency is doing relate to this issue? And what is the way forward? And then I'll ask harder things later. And I would also ask that Ariel would join us in these discussions later.
So it would seem. We're starting with Sally. Hello. Yeah, I think those are amazing questions. I love the notion that the rather impressive turnout we have today is a litmus test of the importance of this topic. I would like to just make 3 points, and I will opt to answer some of the questions that Amanda has already laid out, but really be a little provocative, as I think one must in settings like this, because then I think the discussion we will have after all of this will be very important. And I guess the thing one is, it's about progress. Ariel pointed out the importance of the tractability of health system strengthening. There is a sort of history of viewing this as a bit of a black hole for investment. And the metrics are going to help us not only show that we can move the dial, but they're really going to prove to everybody that this is a tractable problem, that it's something that we can change. One of the things, and this I think will be linked also to value for money from donors, crucial. And I think one of the things that we've seen in some developing countries, in Sierra Leone, for example, when they manage to change the availability of skilled personnel and essential drugs in health facilities, people understood that health systems could get better, and there began to be not only more demand but more utilization of services, improved coverage with assisted deliveries, and while they didn't document mortality reductions associated with those better services, undoubtedly health outcomes were improved. The other thing I think we need to think about is information and communications technology. There is a huge opportunity, not just to digitalize all the data from the health facility surveys, but to really make leveraged communications and information technologies to make this much more real time, so that it's not purely a snapshot. You really can document progress, and you don't have to wait 6 months, 18 months for the next survey, but you can really document that things are moving now. I was in Bangladesh a couple of weeks ago. The management information system guy was delighted to show me his little widget, which was showing at a moment-by-moment basis which health workers in which facilities were checking in for work. And because they can do that in real time, they have seen an 80% increase in the number of people in the worst performing facilities who are actually showing up for work. Wow. That is associated with a huge cost savings and I'm sure also better health outcomes. The last point I want to make is about use. And using the data. I mean, all of us data people love to whine about how important it is to use the data. But here I think it's important to remember that it's not just a matter of being accountable to the donors, which is crucial, but even more importantly, having society more broadly use the data. That means it's got to be local. It means that you can begin to hold people accountable, politicians accountable, managers accountable. And we've seen, for example, just as a last example, in Papua New Guinea, I think they ran out of things to do in the back of the newspaper, and they published a table from the health facility survey that was down to the district level. And suddenly, the governors were voted in or out based on how well their facilities were doing. And believe me, they paid attention the next time. And it became the litmus test of political success, and citizens began to hold their government accountable for having a better health system. So it works. With that, Peter.
Wow, I fear I'm going to be intolerably wonky after that inspiring presentation. Maybe that's not surprising. So thank you very much, Amanda and Ariel. Thank you for those great introductory comments. So I'll just try to respond to the questions that Amanda posed to us, and then see if we'll hope that stimulates further discussion. So the first question Amanda raised for us is it necessary to connect health system strengthening metrics with health outcomes, and if so, why? And I would answer that with an emphatic yes. It is necessary to connect health system strengthening metrics with outcomes. There are several very important reasons. The first, and I think most important reason, is health system strengthening is a means to an end. It's not the end of our efforts to improve health. It's actually a mechanism to improving health. If we don't connect the metrics to outcomes, we're losing track of that connection between means and ends. And this is also very important for a practical reason, which is that there are many health system problems, especially in lower and middle income countries. There are resource scarcities, there are performance issues, and so on. So how do we know which problems are the important problems? It's the link with outcomes that helps us answer that question. The problems that are important are the ones that have the greatest impact on the outcomes that we care about. I want to contrast that with a different way of approaching health systems metrics, and that's what I would call the approach that emphasizes norms, where we look around the world and we say things that we've heard said in the international discourse. Every country should spend 5% of its GDP on health, or all countries should have 2.3 health workers per 1,000 population. Norms are useful in the sense that they're easy to grasp and they're easy to understand, and they provide targets, which is a valuable tool for stimulating policy change. But when we look at the data, when we look at the evidence, what we see is that many countries achieve excellent outcomes even though they don't achieve these norms. In fact, some of the best performing countries in terms of health outcomes are spending less than the norms that have been put forward. So the implication is that using norms has attractions for policy purposes, but it can lead to mistaken conclusions and wasted resources. So that's my attempt to answer the first question. The second question: why have previous efforts to establish global health system strengthening metrics succeeded or failed? And I think the answer first is there are some examples of success and some examples of not so success. I won't call them failures. And I think I'll start with the reasons for not so success. And I think that the underlying causes are really quite fundamental, and they raise challenges for us as people who are concerned about health systems performance. First on the list, I would say, is overall weaknesses in the governance of health systems in many of the countries in which we work. And specifically, the notion that all too often, ministries of health do not really function as the stewards of the health systems that they direct. We would like to think they do. We certainly agree they should. But very often they do not. They really function more like administrators of large systems of people and health facilities. That is, without strategic direction, without really linking what measurement tells them they should do to outcomes. So this is really a difficult problem, and one that we have to work on to make measurement be in greater demand and be more successful. And related to this are the misaligned incentives. When you're basically administering large systems of people and facilities, your incentives are hire more people and build more facilities. And we've seen that in several countries with not such great results. So I think this is an important underlying cause that we need to try to address. But there have also been very significant successes, and I would note two of them. One of them is really the incredible success of the demographic and health surveys, which really have become the basic tool for monitoring progress nationally and globally. And I have to say, this is potentially one of the most powerful investments that the US government has ever made in health in terms of returns per dollar spent. And the second one, I think, which is a partial success, is the adoption of national health accounts, or at least health expenditure analysis around the world as a fundamental metric of health systems. It's an imperfect metric, its measurement is imperfect, its use is imperfect, but it still is the one example we have of something that has gotten out there as a health systems metric. And I think these two examples should give us some inspiration that there's potential for more change. Amanda asked us to comment about how our work relates to this issue, and I want to violate the rules about no PowerPoints simply by showing two pictures. Now, a picture is not a PowerPoint, right? So I'm not really violating the rules. But one of the main things that I've been working on in this area is developing the concept of what I've been calling health systems analysis. And I want to show you two slides. This first one basically emphasizes what I would call the logic of health systems analysis. And this is an attempt to have us thinking about how health systems strengthening determines the outcomes or the performance of the health system. So we start with performance, measured in various ways. We make judgments about the quality of that performance, where we need to improve, and then we link that to the specific aspects of health systems and policy instruments. In this case, I talk about the control knobs, which Ariel has mentioned, but it's not that we have to use that vocabulary. There need to be strategies of change, which bring about changes in the factors of the health system, which in turn affect performance and ultimately outcomes. The key point about this framework, about the logic of health systems, is that we already have a lot of tools that we can use to measure all along the continuum. We have performance measures, we do benchmarking and ranking and valuation of how countries perform. We have many instruments, much of which came out of the building blocks framework for measuring and demonstrating what's actually currently happening in health systems. And then we have an increasing volume of evidence about how policy change brings about changes in performance and changes in outcomes. So the key point here, I think, is to move forward in our measurement of health systems beyond simply describing what is happening in health systems, but actually to the analysis of the causes of poor performance and the design of strategies that fit that analysis. End of pictures. The last topic we were asked to comment on was some thoughts on the way forward, and I think we're seeing a lot of progress in this. I very much liked the fact that already we've had several people mention that we need to pay attention to those who sponsor our work, both internationally and domestically, because ultimately the drive for better health system performance is going to come from national political process and national commitment to change. So I do believe we do need to link aid and domestic investment to performance, to outcomes, and we're seeing a lot of efforts to do that. Things like results-based financing, output-based aid. CGD has been talking about cash on delivery, and yes, we do read the website. So I think there is this emphasis of accountability, and accountability for results means measurement of results. I think we do need to do more work to build and test these causal frameworks. We don't have, in many of the areas of health system strengthening, sufficient knowledge today to draw very strong conclusions about how to proceed. I think we're much better off in the area of health financing, where the evidence is much stronger. I think we're much worse off in areas like governance, where we have difficult problems of even defining our concepts clearly, not to mention measuring them. I think there's great potential for country-based, country-level coordination on HSS metrics, and maybe later we're going to talk a little bit about some of the country-level initiatives like the IHP Plus and JANS and so on. It's in some of the discussion questions. But ultimately, the measurement and the accountability for results has to be at the country level. And donors, as well as national institutions, would be best off coordinating both in the way they define the problems and also in the way they measure the results. In terms of measurement itself, and Sally and I may not entirely agree about this, I do believe that in the medium to long term, we do need inbuilt routine systems to do this. But I think we should take care not to throw away or lose the power of special measurement initiatives too soon. Building routine systems has been very difficult to do, and making them both functional and reliable is a large undertaking. So I think we do need to move on both tracks in this, and as I said, DHS has been a great contribution to that. So thank you.
Great. Karen?
Thank you, Amanda, and thanks to the other speakers. One of the advantages of going last is you can actually build on things that the other speakers have said, and they've brought out very important points for us to reflect on. Also, I recognize that a number of you in the audience are experts on this yourselves, so this is a discussion. Certainly, your inputs are very important. I know there are those of you in the audience who've struggled with these questions considerably in your work. I guess I'll start by disagreeing with Peter, since I guess you wanted a controversial or sort of controversial discussion. And that is on the point of whether we need to measure outcomes, whether we need to measure the link to outcomes. And not to be disagreeable or controversial, but I think that we face two kinds of health system strengthening types of work that we do. There's one kind of work where what we're trying to do by strengthening the system is enable people to have greater access to an established, effective service. So in that case, say, for example, assisted deliveries. If we already know that assisted deliveries actually lead to better health outcomes, then what we need to be able to demonstrate is that the health system strengthening intervention actually leads to a greater access and greater utilization of that service without any decline in the quality of that service. I think if we try in that kind of a situation to go beyond that, we're investing resources in something that's already been demonstrated. So, but that's very different from the kinds of health system strengthening interventions that are much further removed from the health outcome. In a way, paradoxically, the further we are with the health system strengthening intervention from the actual health outcome, the more important it becomes to demonstrate that we're able to accomplish that outcome. And let me take an example. Say we decide that we're going to work on strengthening civil society so that the health system will be more accountable to people, and therefore those people will rise up and demand services, and therefore the services will improve. So that's where we have a higher burden of demonstrating the linkages. I wouldn't say that we have to demonstrate it in every experience, but we have to start with a plausible pathway where we can say, yes, we know that this is a plausible way that our intervention will contribute to this desired health outcome. And we also then have a responsibility for tracking it very closely, because we're working on the basis of a hypothesis and we need to demonstrate that that's actually happening. I think some of the challenges that we face in connecting the health system strengthening metrics with health outcomes are the distinctions between direct and indirect effects. Sometimes what we're doing in health system strengthening can be quite indirect, and then it becomes more challenging. Another challenge from systems thinking more broadly is the challenge of finding that perfect leverage point where a small effort will lead to a great change. That's, I think, why we work on strengthening systems, and that's what is quite difficult to identify. The other challenge with metrics is the challenge of temporality. We start out with an intervention now, and we've talked a little bit about our funders. Our funders want to see the result fairly quickly, but the changes may occur over time. So the challenge is, how do we track the impact in the short run when we anticipate that the long-term result is a sustainable system? Another challenge, I think, is that the investment cycle doesn't necessarily correspond with the change process. And the types of effects that we're monitoring are not necessarily the first order effects of our action. So we can bring about, we can carry out an activity. It has first order effects, second order effects, third order effects, fourth order effects. Which ones are we anticipating and which ones are we tracking? And then finally, I think we've already talked a little bit about this, the importance of having information that demonstrates to our funders that these are good investments. I also am going to disagree with Peter, but only in form, not in substance, when we talk about norms and standards. And I guess I would look at it slightly differently. I'm not saying that we want to enforce norms, but I think we can learn a great deal from benchmarking, where we look at what's going on. If you look at 100 countries and you can establish a pretty predictable relationship between one intervention and a desired outcome, then where is your country? Is it doing much better than that? Doing much worse than that? That's, in a sense, using available information to set norms that are based on empirical evidence, not sort of out of thin air. I recall being told when I was developing one project that I should tell the country that they couldn't spend more than 50% of their health spending on hospitals. And I thought at the time, really, where does that come from? I mean, do we know that that's the pattern? I mean, it was basically just something that someone thought was a good idea. So the other thing, another question that Amanda had for us is, why have previous efforts to establish global health system strengthening metrics succeeded or failed? And here I would say that I have the advantage of, as some of you do, not all of you, I'm not saying that, of having been in this field for quite some time. So when I studied public health in the 1980s, even though it was very obvious that investing in clean water would improve health, there was no good evidence that demonstrated that on a large scale. I also like to remind everyone that before the global initiatives for HIV/AIDS, UNAIDS, PEPFAR, Global Fund, I mean, my recollection in the early days of global work on HIV/AIDS was there was one champion at the Bureau of Census who would literally go around to all of that person's contacts and say, give me what you got. You went on a field trip, what did you find? That was how we were learning about the global HIV/AIDS epidemic. So when we say, we're not where we want to be, to some extent, maybe we need to have maybe a longer view of history. Not to say that we should be slow and take our time, but simply to look at things in a longer perspective. and look at what we do have. I mean, we've talked about many of the things that we already have, and I think that the WHO building blocks, while we can say, it's not perfect, even establishing those then allowed us to figure out, okay, if information is one of the building blocks, how are we going to track that? If health financing is one of the building blocks, how are we going to track that? And that kind of helped us improve our efforts. And we've come a long way in terms of the kinds of tools, as Peter said, that we have available, and the kinds of data that we have available. I think our challenge really is we're not collecting that information routinely. We're also not analyzing it regularly. I was just looking at a health system analysis or health system report on Nepal. Well, the World Health Organization World Medicine situation of 2011, it tracks important information. But the data for Nepal are from 2006. So, I mean, we have the indicators, but how can we accelerate the process of getting that information? How can we stimulate researchers so that they're actually analyzing that information and develop the kind of civil society accountability where there's a demand for that information? And I also, when Sally was talking about the example of Bangladesh, I thought of Yemen, where there's an information system that allows the people at the Central Ministry of Health to know what is in a given facility. So it's an online database of health facilities, and someone, in a traditionally relatively corrupt environment is used to going into the Minister of Health and saying, I need this, I need that, and now the Minister of Health can click on his website and say, oh, well, actually, it says right here that that's part of your inventory. So those are the kinds of things that I think we can work to expand on. And in terms of how our current work relates to this issue, I printed out a copy of something. I don't know if it's available maybe on each, it's for distribution. So let me just talk a little bit about the Global Health Initiative. The President's or U.S. Global Health Initiative has as one of its 7 principles that we will strengthen health systems. And this is not a slide either. This is a piece of paper. So we're good at interpreting the rules on this panel. The Global Health Initiative is posited on the hypothesis that by strengthening health systems on both the demand side and the supply side, we can actually contribute to better health outcomes on a sustainable way. So because that's a commitment of the Global Health Initiative, we're faced with the challenge of how on earth are we going to track that? And as we've talked about, it's a very challenging process. So what we're working on are the metrics that we use for the Global Health Initiative, because each of the countries participating in it has had to say, here's what we think we're going to do to strengthen the health system. And then we have to work with them to figure out how we're going to track that. How do we learn, not necessarily by applying a same formula to every country, but what was your hypothesis in coming up with that approach, and how are we going to see if it really worked? So we're working on that. We're also working on a series of evidence summits where we're looking more in depth at what we know about certain health system strengthening interventions and their links to health outcomes, their contributions to health outcomes. So one of them, which Amanda is actively engaged in, is looking at what we know so far about incentives and how they affect maternal health outcomes, using several different endpoints, both utilization of services as well as eventual outcomes in terms of improvements in maternal survival or neonatal survival. So we're looking at what does the literature say in this area. Similarly, we're having another one where we're looking at what do we know about the factors that make frontline health workers effective. Just looking at the literature. So there's, I think, when we talk about the metrics, there's the sort of 30,000 foot level, and then really the granular, picking up each grain of sand and seeing, what does it tell us. And so in terms of the way forward, I think we have all talked about the importance of donor commitments to supporting data collection. Because there's a global public good element of that. No one country is really going to benefit from inventing this methodology if they're the only ones using it. So how do we help countries improve their information? Another we've talked about is the importance of stakeholders and civil society demand for accountability. We also need to somehow, through financing and capacity building, encourage researchers to use the available data and to hold it up as a reflection to policymakers about what's really going on. And then I think Sally already mentioned the importance of leveraging available technologies that can make this work much more rich and also much more cost effective. From data collection, storage, and transmission. How are we taking what's being learned in information and communications technologies and applying that to this field?
Thank you very much for a very rich discussion. I want to push you a little bit on an idea that Ariel suggested to us, which is that if our goal, if everyone gets around universal health coverage, and it has a pretty specific definition, can we converge around a set of global metrics? And what would it take to get there, in your view? And connected to that, what was wrong or right about kind of the World Health Report 2000 metrics of health system performance? Who wants to go first?
Can we start with the second question? Yeah. So I'll start with the second question because I think that the World Health Report 2000 advanced our field tremendously by defining the components, by explaining the conceptual model, and it led us to develop things that, I mean, if you look at the past decade, the things that have come out, Health Metrics Network, Global Health Workforce Alliance, increased application of national health accounts. So we've come a long way. Biometrics and biomarkers in DHS. Many things have happened, but I'd say one of the challenges with the approach that the World Health Report used in 2000 was that it took a very complex set of factors and kind of merged them into something that was not easily understandable. And it wasn't possible to go behind it. And I can tell you, I was in a Latin American country in the year 2000 where a very angry Ministry of Health leader was essentially asking how his neighboring country, which didn't have control of 40% of its territory, had scored better than his country. And in that country, they actually confiscated the report at the border. So I think it varied too much in one index, and it's a very complex set of factors that we need to be able to see more transparently.
Metrics are controversial.
Yeah.
That's the thing. I think if we want to talk about getting to global measures, one of the things that I think has been lost a little bit from the World Health Report 2000 is the emphasis on financial protection and responsiveness. Those were all of course, we're still focused on health outcomes and we're not done measuring health outcomes well. But as Peter's noted, the DHS is out there and countries are moving forward. So what do you think about all of that? Like, can we return to this field of play and not elicit these very difficult responses?
Interesting questions. I think the World Health Report 2000, I agree with Karen, was a huge leap forward. Just to tackle that was courageous, and I think really advanced the state of the world in this area. But I think, and here I'm going to sound like the escapee from the World Health Organization that I am. One of the problems with it was probably not the technical basis for the report. It was really the process. And unfortunately, God bless WHO, it's often under-budgeted enough that it really doesn't have the resources necessary to engage the countries in generating the numbers, doing the analytics, owning their facts. So this thing dropped on their heads. Yeah. and ministers of health felt sideswiped, and they were. And I think had the report been generated sort of in collaboration with rather than at countries, I think the outcome might have been quite different. So just a plea for better process and making sure that those who own the numbers really own the numbers. And on universal health coverage, that's gnarlier. I should probably be smart enough to avoid responding to that question. But Colden, I think, there's some, I think one of the things that we could do a lot better is capture a more headline-friendly approach to the way in which we do our metrics. And, something that really, and, I'm not the expert, you guys are on this, but, something that's about the injustice of a catastrophic health expenditure, or families being pushed into poverty by because of inadequate financial protections. I mean, those are the kinds of things that if you could put those in your newspapers and make it clear how your country, how your province is doing relative to and this another argument for benchmarking. That, I think, could galvanize a lot more willingness to make progress in this space.
So on the World Health Report 2000, I think the greatest contribution of the World Health Report 2000 was the public acknowledgement by WHO that health is about more than just health status. I think this was something many observers have seen, and if you look at what real ministries of health do in real countries, they do not do everything to maximize population health status. The World Health Report allowed WHO to say that there was more than just health outcomes that are the outcomes of health systems. And I think that was a huge accomplishment. I think actually that is what opened the door to universal health coverage. I think that created the opportunity to talk about financial protection, which has, I think, been the sort of come up as the second most important health outcome, if you will. Something maybe the most important. That said, I actually think that in the period following the World Health Report 2000, we actually saw a bit of a reaction to that, or a backlash to that, which is represented in part by the MDGs, which are very easy to understand measures of very specific health outcomes, at least the ones that we tend to talk about more, although we also could talk more about MDG 1, which is about reducing poverty. And that's, in fact, where the financial protection linkage comes in. So it might be useful to ask, well, why did that happen? Why did that backlash happen? And I think it probably happened because there were relatively straightforward things that could be measured, that needed to be done, that could capture the consensus of most of the countries of the world in a pretty short period of time, because the Millennium Declaration, these things were put together fairly quickly, and they had pretty wide support. So that tells us something about the politics of measurement, that there's something to be gained from something attainable. Now, to come to universal health coverage, I actually think that there is an incredible upswelling of interest and commitment and discussion about universal health coverage, not least in part reflecting some of the hard work that Ariel did over many years. But I do think that we're in a moment now where there's very large interest, but the questions of measurement have not quite caught up to that interest, and that we do need to solve that problem if this movement can be sustained. So there are hard issues in universal health coverage that have to do with how countries balance health outcomes and the coverage with services, and financial protection outcomes and the coverage with financial entitlements. And these are two different dimensions. Coming back to the World Health Report 2000, that helped us put both of these things and some other things on the table. But now we're reaping some of the challenges of that, which are that we have to find a way to keep the momentum or the commitment to universal health coverage going, but also come up with measurements that are sufficiently robust and clear that people can get behind them. And I think some of the uncertainty we're seeing around that now, particularly some of the debates that are taking shape around the famous cube, universal health coverage cube, I think reflect that uncertainty. So this is a big challenge for us going forward in metrics.
Just to add, I think that one advantage that we have now, though, is that we do have the opportunity to benchmark in the sense that at this point there are countries that have actually done this, and so it's possible to say, yes, this is a country where this actually did work. And the fact that the MDG deadline is coming so soon gives us an opportunity to use this window to think about how to do that in the future.
Actually, now's the time.
So one more question, who's going to do this? How are we going to get to this consensus? You've persuaded, I think, well, we'll hear from the audience in a couple minutes what if they're persuaded by our arguments, but how can this happen? Who would lead, et cetera? Okay, we'll leave that for the audience.
Let me offer one thought about that. I mean, I think that it's not that some external authority has to come up with the answer to this question. I think that the answer has to come out of, in a sense, what I would risk calling the market for commitments amongst our clients. That the things that the heads of state, the ministers of finance, the ministers of health, and the civil society organizations will get behind, they will become the answer. And I think actually what we're seeing right now is a number of different things emerging from that, whether it's continued focus on certain very specific outcomes so that we don't lose ground. I think Ariel's comment about setting a goal for prevention of for the ending of preventable child mortality in the world is a good example of that. It's a kind of a politically inspirational goal. You could translate it into universal health coverage in some way, but that may not be the point. The point may be that could be a rallying cry which could support expanding health coverage, right? And I think we have to look for those opportunities.
Just to add to that, I think that rather than saying, okay, it's going to be this organization or that organization, is what are the opportunities that we have to work on this? And probably it's going to happen by working on it together. So what is the opportunity, for example, in the World Health Assembly, in the G8? What's the opportunity in our broader dialogues with other countries? How do we link this to other things that leaders care about? I think it's a question of identifying together as a community what are the things that each of us can bring to this and then working on it together.
Just to challenge you a little bit on that idea, so the International Health Partnership Plus was the health sector's effort to harmonize aid agencies in this space, and they came up with a joint assessment tool, and they've a certain group of agencies applied that jointly in some countries. How do you think that's going? I mean, obviously those are the seeds of the kind of effort that we're talking about. Reflections? I mean, I sort of feel, as someone, another person at a university referred to this, I think it was Andrew Harmer, he said it was a stealth initiative that was not clear what was happening and what's going on, at least to outsiders.
So I can just say that in terms of USAID's participation, we're working with the JANs, but it's really, at this point, it's on a country-by-country basis. So what might make sense is to look at that more as a comprehensive approach. And similarly, there are other things such as providing for health. That's another initiative that brings together some of the same parties, where USAID is working with them on a case-by-case basis, and maybe it's a question of formalizing that and making it more our regular approach.
Yeah, I can't resist. Yeah, the only thing I would add, I think those are good comments. the only thing I would add is that each, I think, partner in the, is it global health? Maybe Ariel is right. Maybe it's cosmic health now. We need to bring it to the next level. Yeah, interplanetary. Each partner brings, I think, special value. And one thing that I think the U.S. government, now having been outside the U.S. for quite some time, I can say that I think the U.S. brings a couple of really important things to this dialogue. One of which is a willingness to acknowledge the existence of a private sector in health, and countries are struggling with it. And I think a lot of donors still are engaged in a kind of ostrich maneuver around the private sector. And I think to the extent that the U.S. can help countries understand the contribution to their health system of their private sector, this would be a huge add. And then the other thing, and you referred to it as well, Karen, and I think is the U.S. is also, I think, very has more of a philosophy of direct accountability to citizens, and I think that could be a real powerful value add in this space as well, and making sure that, because the powerful thing about health systems is people get it, that when they're sick, when their kids are sick, they want access to life-saving services, and that can be, I think, really powerful for people. So I think those two things are things that I think U.S. leadership could really help contribute to.
Okay, go ahead.
So I wanted to highlight one other thing about JANS and the JANS process that I think hasn't gotten enough attention. So I think that, JANS and IHP Plus represent a certain kind of internationally visible effort to improve aid effectiveness, country-level coordination, and reduce transaction costs. Although there are many places where those things are happening outside of the IHP Plus process as well, just by virtue of governments' increasing competence and increasing desire to have partners work together. The one thing I think that was and I worked a bit with this when I was at the World Bank a few years ago, and the one thing I think that has been a bit of a missed opportunity in the JANS process, which does relate to this our topic today, is that JANS is basically an assessment of national strategies. But the question that I think didn't get enough attention is, where do these national strategies come from? What's the analytical basis for these strategies? Once the strategy has been put on paper and adopted by the government, it's not an easy thing to change it regardless of whatever's in the assessment. It's more upstream, I think, that some very important contributions could have been made, better coordination amongst partners and governments to come up with stronger evidence-based strategies, including health system strengthening strategies, that could be embodied in the JANS. When the JANS is actually done, in some ways the horse has already left the barn, right? So, and that, I think, is an opportunity where the partners really didn't pick up the ball, and is an area where more could be done.
That's really true. The last question here for me, and then I'll turn to the audience. If you had to tell the disease-specific programs that the U.S. government runs how to measure success in their health system strengthening efforts, what would you advise them? How could they judge their success? In 5 minutes or less, just some ideas.
So I guess you're looking at me because I work for the U.S. government and I'm supposed to know the answer to that? Okay. I think we have to start with what is the disease program trying to accomplish? And then what are the elements, an analysis, as you said, of what are the health system constraints to achieving that, both now and in the long run? And a clear understanding of the relationship between those health system constraints and the outcome, and then tracking of what have you done to change those health system constraints. So it's going to be different if you're doing immunization than if you're doing tuberculosis or if you're doing HIV/AIDS. And I think if we're talking about element-specific health system strengthening interventions, it really should be based on an assessment of what are the constraints. The challenge, as I mentioned earlier, is the temporality, the change now and the change over time, while you're providing donor assistance or after you retire that assistance. Yeah.
Now that Karen has broken the way, we can we can come in. I'm really glad to hear you talking about grounding this question in an analysis of health system constraints, because I think one of the dilemmas in this very difficult question has been that just about everything in a development project or a program is health system strengthening, if by that we mean things that affect the health system which bring about better outcomes. I cannot imagine a project or a program whose goal was health system weakening to bring about better outcomes. So we're in this risk of being in a kind of a, it's everything, and that's not very helpful. So I think the way out of that dilemma is to distinguish between things which are just essentially additional supplies of basic inputs, which are very important and need to be assessed in and of themselves, and things which change the way health systems function, alleviating those constraints as you talk about. And at the margin, those are the particular contribution of health system strengthening, I think. So I think that's really the way we should try to take it forward.
Yeah, well, I think you're both right. I think that's, and I don't really need to add too much. The only thing I would say is that while it may never be the stated goal to engage in health system weakening, I think disease control projects can occasionally, and here, unfortunately, public health, there's no Hippocratic oath. There's no, first of all, do no harm. Because sometimes in a frantic attempt to kind of ruthlessly pursue a disease control goal, one does set up separate and parallel training systems, separate and parallel, supervisory systems, and that can in fact do harm. So I would just add that caveat. I think the good news is in recent years it's been increasingly recognized as hopelessly antisocial not to pay attention to those things, and I think we see less damage being done now, and there's more conscious effort to really use indigenous health systems rather than creating a separate support system for a disease control program. So all good.
Okay.
May I just add one thing, because I think that's a very important point. I think also that the studies that have looked at these disease-specific programs and their impact on health systems have found a more nuanced picture where, in fact, sometimes they actually do strengthen the health system. And I think of the case of malaria where, if you can actually bring down the caseload that the health system faces of malaria cases, you can give the health system the slack it needs to actually get other things done. So it's a mixed picture, but it's important to track it.
And I mean, certainly USAID has funded a lot of work looking at the system-wide effects of the fund and other disease-specific programs. Okay, I think we'll turn to the audience now, and I just wanted to say one little thing, taking advantage. One of the unintended consequences, perhaps, of our new emphasis on results and metrics, even COD aid, is that we are increasingly wanting to document and measure donor efforts in country. And in some cases, that has led to a boom in data collection efforts that don't necessarily help with the building blocks of the data collection that we care about. So I just wanted to say a little bit about that I don't think we've paid enough attention to that. But now, the audience, go ahead. We have someone coming with a, can you also introduce yourself, say where you're from, and ask your question, try and speak loudly for everyone.
My name, can you hear me? Yes, my name is Susie Peel, and I've worked in various capacities, mostly focused on children and low literacy audiences and so on. But I've been aware for at least 10, 12 years now of the need to address what was the title of today's event, which is linking the inputs, the investments, to the outcomes. And it seems to me a desperately dark box. If it's not a black box, it's still a dark box. And I would like to know where progress is being made. I mean, to go to Ariel's point and push this way into the future, how much does it really cost to avert a childhood illness? You know, there are plenty of donors who are investing an awful lot of money. Are we able to answer them even with an order of magnitude? I was doing this work in children orphaned by AIDS, and it was between $3 a year and $12,000 a year to care for one orphaned child. We just weren't counting the same things. We didn't know what to count. So where are we on the investment to outcome? Thank you.
Great question. Let's take two more from the audience.
I'm Diana Pinto from the Inter-American Development Bank. I'm a health specialist at the bank. I just want to bring forward an issue from the perspective of the bank, perhaps, if I may take the role of governments, which is what is the perception of health system strengthening when you go out to give a loan. I would say, I agree with Peter, I would say that basically there's no health loan that has the word, that doesn't have the word strengthening, in our case, fortalecimiento, in it of some sort. I've come to almost hate the word because it has to be there all the time. And how do you measure that? When our work many times is motivated by governments themselves, and what goes into health system strengthening strategies is what governments think is strengthening their health systems, such as capacity building, more human resources, infrastructure, et cetera, and you have to come up with these indicators to measure what you're doing. So just to give you a very simple example of the complexity of actually measuring this, for example, you do some capacity building project in a Ministry of Health. How do you measure that? Just by people who took a course? I think it should go on to measure something like better decisions or something like that. But collecting that data, getting it to act, well, it's really a challenge. So again, the question is, how do we move forward in that direction in a more systematic way, rather than each project coming up with the creativity to measure the indicator in some logical form?
I think I worked on that log frame, right? So like at the top you have the MDG, and then below you have some like totally unconnected health system strengthening activities, but that's something to think about. Rena?
Rena Eichler from Broad Branch. I wonder if you could talk a little bit about attribution. You know, one of the issues, many donors would like to know that their money contributed to this health system strengthening, or part of strengthening a system that led to these health outcomes. That's one question. Then the other is, there's a lot, at the same time as we're talking about metrics for monitoring and measuring what happens in a health system, the link to health outcomes, there's also a whole other focus on evaluation, and with that comes, you know, how do you know that this intervention led to this outcome when so many things are happening simultaneously? And wonder what your thoughts are on where these two things intersect. Thanks.
Three great questions. So the first one was, if we want to link investments to outcomes, what real progress has been made on this? And we don't really even know what determines a lot of the differential costs that we're seeing in different settings. And I think that's a very true and difficult issue, although I know that there's some progress on costing tools that maybe people can talk about. The second question was, we're always funding these kind of standard categories of activities under the title of health system strengthening, but it's really unclear what the connection is to outcomes. And I don't know that we even, how much is so specific to a given context and how much could be generalized. And then Rena asked about attribution requirements by donors, showing how these investments in health system strengthening are contributing to outcomes, and whether it's worth investing in that attribution, and whether you can do impact evaluation around some of these issues. And I would say that you can, but I don't think that it's not very sexy yet. So go ahead. Karen.
Thank you. This is where I begin to feel that it would have been good to be in the audience, because I read the sort of write-up that Amanda wrote, and I thought, my goodness, whoever's going to answer these questions, I'd love to hear what they have to say. So, investment to outcome. I think that one of the things that we're finding, particularly in this evidence summit on maternal health and the role of incentives, is that there's a long way to go in improving the collection of evidence on what does it cost to produce an outcome. Even in well-designed studies, it seems to be a weakness. So I think that there's work to be done to improve our ability to look at the cost of producing particular outputs. And I would say that goes beyond health system strengthening interventions. That's just, I think, a problem with our field. And in fact, one of the studies that we're looking at for this review that we're doing is on the impact, the cost and the results of introducing vouchers in Bangladesh for access to assisted deliveries. And one of the studies actually did estimate very well that it cost about $70 for this voucher program to give someone access to an assisted delivery. But frankly, there was no comparable evidence on other kinds of interventions. So you can't say that's a better choice than something else because the others aren't collecting the evidence. In terms of health system strengthening being kind of everything and anything you want it to be, you just kind of call it health system strengthening. I mean, that is a challenge, and I think partly because this field is still growing, and that's why I think it's so important in the development of health system strengthening interventions to explain what is your pathway, your hypothesized pathway from what you're doing to the outcome you're trying to accomplish, and then actually putting approaches in place to track that. There are very good ways of tracking how did your training program change performance of service providers, but that step is not always taken. It's possible to do, and it's, I think, kind of state of the art to do that, but not everyone does that. Attribution, I would say they're kind of, in a way, two sides to attribution. There's the marketing side of attribution where, we want our policymakers who produce resources that we are going to use to feel that we're really getting a lot for our money. And so we tend to attribute anything we could plausibly say we're associated with our efforts. Then there's the learning part of attribution, which is really understanding what was our contribution, how much did the results change as a result of specifically what we did. And I think we have to do those things, but not confuse one for the other. And that's not an easy answer or perfect answer, but I mean, that's, I think, our way forward.
The other thing I was thinking is, training, just as an example, if you actually look at the uses of donor spending, there's so much spent on training. I think it's like a third of our spending is on training, and we really don't know what the relationship of that, and this is not something that's always labeled health system strengthening. It's used by all kinds of programs. But, I don't think we've made that connection in all cases, or it's not generally known. And then, of course, there are impact evaluation ways, and you've described some of those.
Okay. They're very good questions. So coming to the question about investments leading to outcomes and costings, I found myself listening to these questions and thinking to each of these questions there's a political answer and a technical answer. And we should try to distinguish between those two. I think that I've been involved in a couple of exercises which have tried to answer questions like how much would it cost globally to achieve reproductive health, or how much will it cost to achieve the MDGs. Many of you remember the exercise that was done for the high-level task force on innovative financing. And these, I think, are to a large degree political questions. And when people sit down to try to answer them, they try to do something that is technically understandable and would withstand some review, but they also try to come up with an answer that is politically feasible, okay? And that's fine. I mean, that's good, because mainly the purpose of these studies is to show that something is achievable for an amount of money that you don't shake your head and go, that's impossible. Right? And I think we've learned over the years that in fact a great deal can be achieved for the kinds of resources that can be marshaled in global health. So I think that the issue there is not so much about methods, really. That the other observation about costings is that I think we have perfectly good and usable methodologies, technically sound methodologies for costings. But one of the things we learn all over the world is that the costs of healthcare delivery are highly variable. They're highly variable in the United States. Some of the most controversial, or not so much controversial, but powerful messages that have come out of the recent discussion in the United States is how much unnecessary care is taking place, why are costs so high in some places and not in others. And we see this variability everywhere in the world that we look at the cost of healthcare. I don't think that should surprise us too much. First, a lot of healthcare is discretionary on the part of providers. So there is no single uniform practice. And also the prices of inputs vary a great deal across countries. So I think this is just the nature of the environment in which we work. And so the question, what does it cost to do X in a global sense, is really not a very sensible question. We can say on average it costs this to do X, but then that doesn't tell you what it's going to cost to do X in a certain place. At the same time, we can do perfectly good cost projections and planning with costs for projects and things, and I think that's a very sound area of work, and we can do more of that. We do a lot of it. So it's important to distinguish between that political and that technical aspect. Similarly, with the question of what to measure about what health system strengthening is doing at the margin, again, there's a political and a technical question. I think the political question is really about retaining support for investments in health system strengthening. And there, since we're making progress in health, and we're making it while we're strengthening health systems, I think there is, a fairly basic positive argument that can be made. On the technical side, though, it's a little bit more difficult, and I personally don't think we're going to come up with very sound, rigorous impact evaluation of broad health system strengthening investments producing X amount of change in mortality or morbidity or whatever. A professor of mine I studied with many years ago in graduate school, Jean-Pierre Habicht at Cornell University, introduced the concept of adequacy in evaluation. And that is, are things moving in the expected direction given the investments that you're making? And are the investments that you're making within a sort of reasonable range? So, and I think that's probably the most useful way to think about this evaluation question. And finally, the question of attribution, just again, this is very much a political question. Because each funder, partner, and so on wants to be able to say what their dollars are producing. I actually think we should try to resist this. I know sometimes the people who have to answer these political questions can't resist it, but the movement towards greater country-level coordination and aid effectiveness actually militates against thinking this way. And when you see these kinds of reports, at least I think, in the privacy of our own homes, we should, sort of cast a careful eye on them, because it is very difficult to say what this particular World Bank project or IDB project or Global Fund project has produced in terms of outcomes, because in most countries they're all working together and in complementary ways, and they should be doing that. That's a good thing. So I think, again, this is really mostly a political question.
Heresy. Impact evaluation. Okay, go ahead.
Well, just quickly, I think most of what needs to be said has been said, but I think Karen's early remarks on the subject of sort of attribution and contribution, I think, were important, and that and I'm realizing you're right as you read the title of this event. We've got measuring, we've got effectiveness, we've got linking, we've got investments, we've got outcomes. There are a lot of measurement issues here, and I guess I would just make a plea for being pretty militant in our own minds about how we separate monitoring, which is about managing and being kind of responsible kind of program managers, from the sort of implementation science or randomized controlled trials. And attribution is a randomized controlled trial question. Contribution, I mean, you can often make a plausible argument that something has changed, and it changed partly because of what you did. And I think you're right, we need to be comfortable with that. And we need to make sure when we design monitoring that we don't measure everything we want to measure, and that we leave that for the implementation science, the highly funded research settings where you need to prove something.
Let's see. So we have about 10 minutes left. Ariel, do you want to make any comment about what you've heard so far? And then we'll go back to the audience, just out of curiosity.
Well, thanks. I need a microphone, so I will stand here. But I certainly hope we can do better in terms of the measurement of coverage. And I think people spoke of 3 dimensions of coverage, I guess. One is the access, one is the quality of the services or satisfaction, one is the affordability of the financial protection. So I think those 3 dimensions are well set. And I think that who gets covered formally, depending on what you define for the coverage, is also something that can be measured. I think the financial protection in terms of the proportion of your expenditures that is out of pocket can also be measured. The quality issue satisfaction, what gets covered, is a more difficult proposition because it depends in each country on burden of disease and economics and some politics. But in the end, there's a minimum package of services that people can agree. I think we can measure those things, and we should really stick to those things because they're important, they're clear, and they can be measured, but we're not doing it as systematically or as well as they should. And so some overarching measure of the 3 of them is what coverage ends up being. I think it's not too complicated, but we need to agree to a measurement because in the end, it's not going to be perfect. There's no perfect parameters and no perfect indicator in the real world. One thing I would say, I'm a clinician, and I was still seeing patients last year at Columbia University where I'm a professor of clinical medicine. And in medicine, it's about your patient. We recently have learned to appreciate Bayesian probabilities of the population to make your diagnosis, but in the end, you feel accountable to the patient and to make a difference to the patient, and that's that. I think in health systems we should do the same. We should not allow somebody doing some sub-threshold intervention to count as a health system intervention. That you should really think of what is the model specification that you have in mind for your work, and it's about the system. And so what are the interventions and what are the outcomes in the system? And at that level of scale and sustainability, that you are making a difference or not. Because otherwise, if everything is going to count as health system improvement or strengthening, you're going to get lost in nothingness. The worst part is that people may not be able to understand or appreciate the possibilities of bringing change at even a greater level. And Amanda has made the case of Ghana famous by now, but in Ghana, which is maybe a good point, a good case in this regard. If in 2003, Ghana had less than 5% coverage in the population, and they were spending 60% out of pocket. And they were spending per capita, I don't remember the amount, but it's exactly what the GDP of Ghana will expect Ghana to spend in. And Ghana introduces legislation, very clear legislation. Ghana now has an aspiration for universal health coverage, and it introduces a 2.5% increase in the VAT tax and a 2.5% increase in the Social Security income tax, and pours that into a new institution, the National Health Authority, Insurance Authority of Ghana. And it creates a new institution. It changes the game, and this costs money, because the changes are not service provision. It's creating a new institution with new management and all that. It costs Ghana approximately 2% of the total health expenditure over 3 years to reorganize the system away from what was an out-of-pocket, low coverage, into a modern-looking health system. And 2% of the total health expenditure over 3 years. That's about, I think Ghana was 30 or 40 million a year for 3 years for an investment. What did it buy? Coverage. They went from 5 to 50, 60, depending who you ask. The government 70%. That's okay. The National Health Account does suggest that the out-of-pocket expenditure did decrease from 60% down to maybe close to 40% now. That's pretty good. And if the government continued to invest, because that's the challenge, to make sure that the public investment or the pool investment crowds out the private out-of-pocket investment. That's something that can be measured, easily measured. And I'm also happy to have read Mensa's paper in 2010, where using instrumental variables could compare population cover versus population not cover, adjusting for their income, their education, all the things that normally should matter, and showing that those who now had coverage had an increased antenatal care visits, number of visits, that had lower maternal complications, birth complications, and had lower infant mortality. I mean, there's no magic to doing this type of evidence and this type of studies. We need to do a lot more of those. And again, unless we are focused on the right scale and on the right temporality, we can waste a lot of energy on little things. So I would like to say, just lift out your head and think, if those are the three parameters, if it's access, affordability, and quality satisfaction, make sure that whatever interventions and outcomes we measure really, really make a difference there, and that we have ways to measure that. It's not too difficult. Once you're making a real difference at scale in those three dimensions, the precision will be less important. I worry more about making sure that we are aiming for the right target. So, thank you.
Very excellent intervention. In fact, I almost feel like ending on it. Is that all right with everyone? Because I think you did have the last word, and it was a good one. So